Now it's my great pleasure to introduce Patrick Conway, the President and CEO of Blue Cross Blue Shield of North Carolina, which insures nearly 4 million people. Many of you know Patrick as one of the driving forces behind the movement to value-based payment. As the most senior non-political executive at CMS, he led the successful introduction and conversion to alternative payment models. In his time at CMS, he had many titles and roles: acting administrator, principal deputy administrator, chief medical officer, and director of CMMI. His service at CMS spanned 3 administrations, both Republican and Democratic. Patrick is also a practicing physician. Prior to his government service, he was at Cincinnati Children's Hospital, where he was the director of hospital medicine and an associate professor. Throughout his career, he has continued to work directly with patients. And as you'll hear, Patrick is passionate about investing in and accelerating innovation. And with that, Patrick, will you come up?
Thanks, Nancy. Thanks, Nickham. It's great to be back here in Washington, D.C. in a lot of ways. Also scary at times in a lot of ways, but overall, great to be back. So, you know, as was mentioned, I love the title of the session, Reimagining Healthcare. Actually, at Blue Cross North Carolina, just earlier this week, we talked about, with our people leaders, imagining what's possible. And I think across the public and private sector, I'd encourage all of us to think about what's possible. And what I mean by that is we need a higher performing health system that achieves better health outcomes at a lower cost and a great service experience. And we need to work on that across the public and private sector. You know, as Nancy mentioned, I had the pleasure to serve 4 secretaries of health and 3 presidents through 2 tours through government, both Democratic and Republican. Ended up being the longest serving chief medical officer and the longest serving CMMI director. And I always kidded, I'm not sure what that meant about me or the job. But there is actually a lesson there about the challenges of public service in this country, which I won't talk more about today, but I do think there's real issues about how we support public service workforce. You know, I've had 8 months now at Blue Cross North Carolina and really working on a similar set of issues. As was alluded to, I will weave in data and patient stories. To give one example, I still practice taking care of mainly children with multiple chronic conditions, and actually, when I was in DC, cared for a mother and child multiple times. And if I care for you multiple times, because I only take care of hospitalized children, that's usually not a good sign. This mother ended up electing palliative care for her child who passed away. Then several months later, I see her in the hall at CMS, and she had transferred across the federal government to work with us at CMS because she wanted a higher performing health system for children like her children and for families like that. So just to bring it home. So I'm gonna talk about change today, and the major thesis, and I'll come back to this, is our health system. I was on a panel recently where we talked about our health system is changing dramatically to move towards value, and we'll give some examples. On that panel, they actually said we'd had more change in the last 3 to 5 years than ever in the US health system. I think that's probably true, but the issue is we still have a lot of improvement to do. So I'll challenge us collectively to move faster, to innovate, to drive change at a much more faster rate. And that's because people across the nation need our help. This is our mother. This is my mother, not our mother, as far as I know. It's just Mother's Day. She's a Medicare beneficiary. When I was at Medicare, I used to say, you know, we gotta help all these Medicare beneficiaries because they're all our mothers and fathers. And I realized mothers resonate with people even more than fathers, by the way. So I talked to her most days on the way into work. Talking to her one morning, and she goes, you know, Patrick, I got this letter from my doctor. It says I'm in this thing called an ACO. What's an ACO, and should I opt out of it? And I'm like, oh my gosh. I'm like, Mom, as the chief medical officer of CMS, I cannot tell you what to do. But as your son, like, this is what we talk about every day, and can you not opt out of the ACO? So she stayed in. Fast forward a year or so, I realized she has pneumonia. She gets hospitalized for 22 hours of observation IV antibiotics. That's a story for a different day. But then she gets discharged to home. And she gets a call from her care coordinator. who says, do you have the medicines you need? Do you have a primary care appointment? Do you have transportation? Which is, she won't let me say her age, but she's been in Medicare for 15 years. So all reasonable questions. And it's about a system that supports people outside of the office visit. So in North Carolina, we have ACOs today. Many of them, one example, saving $20 million, improving quality, but it's all about a system that supports people across our healthcare system. So, in CMS, we talked about this a lot, and it's a very similar framework we're using in North Carolina. How do you move from a fee-for-service, volume-driven system to a value-based, patient-centered, accountable system? And to give a tangible example, I've led P&L in provider systems. I've led, complex, large provider systems as well. When the incentive is around volume, there's literally a saying about heads in beds. How do we get more heads in beds, which is a CEO, CFO saying. That is the opposite of what we want in America. I have never met a single person or family that got hospitalized that says, I'm really happy I'm here. I hope I get to come back soon. Like, no one actually wants to be hospitalized. So how do you reorient the incentives to prevent hospitalizations, around prevention and wellness, and really around accountable care? And we're using a framework very similar to what we originally published out of CMS and then was adopted across public and private payers. One, a fee-for-service system, totally volume-driven. Two, fee-for-service with a link to quality and cost. Three, alternative payment models. So these are models where the provider is accountable for quality and total cost of care. And then four, really population-based payment. And we, similar to when we were at CMS, are pushing to models 3 and 4. And we'll talk a bit more about that later. If you think about how did CMS do, and when you leave DC, you get to sort of reflect both on what went well and what you wish you would have done differently. But in the what went well category, I think, I remember starting at the Innovation Center, and at that point, we had literally, $0 in alternative payment models. So there'd been some demonstrations before or so, but essentially $0 at that point in alternative payment models. Fast forward in early 2016, we reached over 30% of payments in alternative payment models, a year ahead of schedule, which was over $200 billion and over 200,000 signed provider agreements with hospitals, physician groups, others across the country. Did they all work? Of course not. We learned from a lot of them. Some were successful. I'll give you two examples that aren't talked about quite as much. The Next Generation ACO program looks like it's taken about 2% off trend, and it's significantly improving quality and patient experience. The ESRD ACO program, which people don't talk about much, but is taking about 6% off trend and significantly improving quality and patient experience. If we took 2+% off trend in Medicare, you're talking about a much more sustainable future. So just to give you a few examples. This I wanted to share. This comes from Niall Brennan, who's now CEO of the Healthcare Cost Institute and was our chief data officer at CMS. I just think the slide is really telling. Essentially, I won't bore you with all the detail, but utilization across spend categories is essentially flat or negative, but prices have gone up so much that the total cost of healthcare is going up dramatically. So we have a serious price issue across areas in this country, and the question is, how do you get price under control? I know others will talk about drugs and other arenas in a way that lowers costs for consumers. And I travel around the state a lot. A farmer I met with recently, small business farmer, $40,000 for her family in premium and out-of-pocket cost. This is not sustainable. 85% of that's medical costs. We have to bring down medical costs, and price are a large part of that. So I'll shift now to Blue Cross Blue Shield of North Carolina. As was said, almost 4 million members, about 5,000 employees. I met and shook all their hands at their desks, which was exciting. We're about $10 billion in revenue now, nonprofit health plan. The most important thing, I think, is the last bullet, and is really why I took this job. We ensure the majority of people in North Carolina, across commercial, individual marketplace, Medicare, and soon to be Medicaid, which I'm going to talk to you about, are competing to be Medicaid. And we insure the majority of them for the majority of their lives. I literally meet people that we have insured them for 70 years. So the opportunity to drive change in that environment is huge. And as a nonprofit health plan, any profits we make, we reinvest, and we'll talk about this, into the health of people and communities, which I think is the beauty of the Blue system and Blue Cross North Carolina. So how are we moving to value? First, provider partnerships. We have over 80% of payments value-based today, but the vast majority of them are plus or minus some percent based on quality and cost. We believe, we do have ACOs, bundled payment, those are saving money, advanced primary care medical homes, but we believe we can move over 50% of payments into advanced alternative payment models with providers, including two-sided risk, over the next 12 to 24 months. And that's the discussions we're having with providers right now about deep partnerships to shift how you pay for and deliver care. You know, in the primary care arena, you know, we think we can, through partners in the state and, you know, partnering with other people across the primary care spectrum, that we can bring 24/7 primary care access, telehealth enabled, you know, that can be stratified so you have, you know, primary care providers that are taking excellent care of really sick people and saving money and improving both quality and patient experience. On improving health, we're making major investments in improving health outcomes at scale. I'll give you a couple examples. We're looking at partnering with some companies that have data that looks like, if not only dramatically improves diabetes, literally may cure diabetes. So could you cure 10,000 diabetics in North Carolina? We're making huge investments in social determinants of health. So we made a $50 million investment around social determinants of health, including early childhood development. Last example, and I'll let Peter talk more about this because we're very early stage, but could you partner with a pharmaceutical company in the Hep C arena, for example, and say we want to treat everyone or everyone we can find with Hep C, and we're willing to pay for that at a population level to try to eradicate or as come close to eradicate as possible Hep C at a state level. So just a few examples there. On consumer resources, we were the first health plan to put out transparent information on quality and costs. That predated me. We now have over 1,400 procedures online, app-enabled. We fundamentally believe we have to get data to consumers, to providers. We have to view data and transparency as a resource. And then primary care, I talked about some of our work in primary care. This is just one of the programs we already have, which is Advanced Primary Care Medical Home. As you can see, significant reductions in inpatient utilization and outpatient care. And now the question is, how do you take that to the next level? As you know, we're like most payers. Less than 10% gets invested into primary care. The primary care controls probably 80+% of the cost. So how do you invest in primary care to change the dynamic? Related to this, we're looking closely at mental and behavioral health and making major investments. So, you know, how do you invest in telehealth and mental and behavioral health, invest in integration in mental health, integration of mental and behavioral health into primary care? You know, our goal is to become a high-quality payer that delivers reliable mental and behavioral health so people have access to it reliably and integrates it in the overall care experience. Does not silo it off, but actually integrates it both financially and from a care delivery model so people receive the care they need. Medicaid, briefly. North Carolina is the biggest non-Medicaid managed care market left in the country. It has said publicly it wants to move into Medicaid managed care in late 2019. We plan to bid on that business and would like to serve that population. And once again, it really is, it's almost 2 million people in North Carolina. But for us, you know, it's not about a revenue stream, et cetera. Ooh, I changed the lights. God has spoken.
It's a good sign.
Yeah, except for it went dark. I don't know, on me. But, you know, our focus really is, you know, how could you deliver amazing care to this population? How could you deliver integrated mental and behavioral health, address social determinants, you know, tremendous primary care? So that's really our focus in the Medicaid population. We're also working with some partners on how you could screen and address social determinants at a state level. So just briefly on the Blue system, and Pat may say more about this. You know, the Blue system, broadly, we care for over 100 million Americans. And I think it is and can drive in the future even more positive force of change. You know, in most states and communities, the major Blue health plan not only is a pillar of that community, but it is the delivery of so much healthcare. And so when we talk, and I know I've learned a lot from Pat, when we talk to our colleagues across the Blue system and Nancy and others, it's how do you utilize that to drive major change in the health system that achieves better health outcomes at a lower cost and a great service experience. And I think the Blue system has a major role to play in that change. And nothing, I know Gail made an allusion, nothing against our for-profit health insurance colleagues, but it is fundamentally different at a core mission-driven level. Like the employees I interact with, it is a core mission-driven focus on driving change. Actually, I'm gonna tell one story there, if it's okay. I'm still okay on time. We had a 3-year-old who we found out wasn't getting a life-saving medicine that he needed. Good news is, fixed it in less than 60 minutes. Second piece of good news, the team, before they even knew I liked lean, did a lean process review and identified all the failures that occur, and so we can prevent them in the future. I called those parents. It was painful. To hear what they experienced in our system by well-meaning people was really challenging. I listened to the customer service reps that wanted to help them. This actually led us to a focus on treating every customer like family and giving more ability for our customer service reps to escalate and solve issues on the fly, instead of saying, the protocol says you didn't check X box. Sorry to riff on this one a little bit, but we have a net promoter score in the teens, which is actually really good for a health plan. But if you got to the 30s, you'd be the best health plan in America, measure of customer satisfaction. And could you even go beyond that? And I know some of my colleagues on the stage are doing incredible work in this area as well. But how do you deliver a customer experience that's seamless and like nothing people have experienced before? So we're working on maximizing partnerships, keeping members and communities healthy, supporting the delivery of outstanding care, and developing the next generation of capabilities. In closing, I would just say I'm only 8 months into this job, and I loved my time at CMS. I think we did a lot of terrific work. I also am incredibly excited about this new role because the pace you can drive change at a state level at Blue Cross North Carolina has just been incredible, and a great team of people. Terrific work at CMS, now terrific work on Blue Cross, at Blue Cross North Carolina, and look forward to the discussion. Thanks a lot.